We are honored today to have Dr. Pascale White for her grand rounds on breaking down the barriers, disparities in colorectal cancer screening in African Americans. Dr. White received her medical degree from George Washington University School of Medicine and Health Sciences in Washington, D.C. She subsequently completed her internal medicine training and chief residency at NYU, and then went on to complete her fellowship training in gastroenterology at Memorial Sloan Kettering Cancer Center. Dr. White currently serves as an assistant professor here at Mount Sinai. Dr. White's research interests are in colorectal cancer screening with a particular focus on health disparities in screening of African Americans. It is in this area that Dr. White has published multiple articles. Dr. White is also actively involved in medical education at the student, resident, and fellowship levels. Please join me in giving a warm welcome to Dr. Pascale White.
Good morning. Thank you so much for that warm introduction, and thank you to the department for inviting me to speak with you all this morning. I do not have any disclosures at this time. And so this morning we're going to focus mainly on screening. Okay, we're going to discuss the rationale for earlier colorectal cancer screening in African Americans. By the end of this talk, we'll be able to recognize the patient-related barriers that African Americans face in obtaining screening. We want to identify the physician-related barriers that exist in recommending screening to this population. And we'll also discuss the approaches taken to increase colorectal cancer screening rates among this group. So this year, the American Cancer Society has estimated that there will be about 151,000 new cancer cases for colorectal cancer. It is the third most common cancer in both men and women. The same year here, it's estimated that there will be about 51,000 deaths related to colorectal cancer. Among men and women both, is about the second leading cause of cancer deaths in the United States. Now, 80% of colorectal cancers follow the chromosomal instability pathway, in which patients who initially have normal epithelium undergo a mutation in the APC gene, and from there, early adenomas form. Between early adenomas and late adenomas, various mutations occur, where there is a KRAS mutation gene, a SMAD4 mutation gene, and ultimately later in the pathway, a P53 tumor suppressor gene develops ultimately into carcinoma. Between normal epithelium to carcinoma, this pathway takes about 10 years. Now, this is a cartoon depicting the stages of colorectal cancer and the associated 5-year survival rates. Now, from stage 1, or the primary site of colorectal cancer, we see the survival rates of 94%. By the time that it reaches stage 2, where it's invading into the muscle layer of the colon, it's 82% survival. By stage 3, where there's local regional lymph node invasion, we have 67% survival rate. And by the time it's metastatic disease, or stage 4, we have 11% survival. So we see over time, diagnosing cancer early can save lives. Now, patient risk factors for colorectal cancer, we can split that up into modifiable and non-modifiable risk factors. Those considered non-modifiable would include age, above the age of 50, where in average risk patients, about 90% of colorectal cancers are diagnosed. Those with inherited genetic disorders are considered to be, again, a non-modifiable risk factor, like FAP and Lynch syndrome. And race is also a non-modifiable risk factor. Modifiable risk factors are what we usually explain to our patients in terms of weight control or obesity, alcohol intake, smoking, diet, and we also consider socioeconomic status and access to care insurance status to be modifiable risk factors. Now, what are the various colorectal cancer screening tests and guidelines available to our patients? And so for the average risk patient, they have a myriad of choices to undergo colorectal cancer screening, and we split that up between detection tests and prevention tests. Those with detection tests, we consider those to be non-invasive measures, usually, first of all, the fecal immunochemical testing or FIT testing that can be done annually. This is only one sample that our patients have to submit, versus the Hemoccult Sensa, so also guaiac-based stool testing, in which you have to submit 3 samples to do so every year to consider it to be screening. And then your fecal DNA, which is done every 3 years, and this is a test that's detecting human hemoglobin and DNA that's shed from cancer cells in the colon. And again, that's done every 3 years. Your prevention test, as we all know, is a colonoscopy every 10 years. Your flexible sigmoidoscopy every 5 years, and your CT colonography, which is a radiographic test, every 5 years. Now, this is just a nice table just depicting the sensitivities and specificities of each of these testing for for your review. And so we see here in terms of FIT DNA, it's about 80 to 92% in terms of detection of colorectal cancer, and down to FIT is 60 to 80%, and for your guaiac testing, it's actually less than 50% for colorectal cancer detection. With regards to adenomas, we see here that for FIT DNA, it's size dependent, about 60 to 90%, 40 to 60% for FIT, and less than 20% for guaiac testing. Specificity is great around the board, in which is in the high 90s for each of these testing modalities. Now, in terms of our invasive testing for colonoscopy, we see that it has the best sensitivity and specificity here with regards to colorectal cancer and adenoma detection. Sigmoidoscopy, again, is only looking at the left side of the colon, and so we see here that it's about half as much for colonoscopy in terms of the total, but for distal disease, in which it's detecting, it's 95% sensitive and 92% specific. And CT colonography has pretty good colorectal cancer and adenoma sensitivity, but the specificity is a little bit lower at 86%. So what are the screening guidelines here? There are various societies that have gone over what would be the average age that patients should get screened. So United States Preventive Services Task Force in 2016, their latest guidelines, as well as the United States Multi-Society Task Force, which is basically a task force comprising of the 3 national GI societies, came out and said that average risk patients should begin screening at age 50 and continue until they're 75 years old. Between 75 and 85, this should be individualized based on a patient's comorbidities and their ability to undergo colorectal cancer treatment if it were to be diagnosed. Now, the American Cancer Society came out with their guidelines in May of last year, and they essentially lowered the average screening age to 45. And the impetus for that was because of the increasing data on early onset colorectal cancer. And so they are actually the ones pretty much leading the charge in terms of considering everybody to get screened at 45. And they also say no further screening after 85 years old. Now, the ACG, or the American College of Gastroenterology, put out a separate clinical guideline, and this was come out in 2009, and these guidelines were created by the Minority Affairs and Cultural Diversity Committee. And what they said is they reviewed the literature, and they deemed that African Americans were at high-risk group that should be screened earlier, and that age should be 45 years old. Now, this review was updated by the Minority Affairs Committee, comprising of Dr. Williams and myself, who published this update, not only readdressing the literature, but also addressing new topics such as physician-related barriers to screening. Now, let's go into the rationale for earlier screening. Statistics for African Americans here in the United States. In 2016, 43 million African Americans were living in the United States, comprising 13% of the population. In that year, about 190 new cancer cases were diagnosed and 70,000 deaths were estimated. African Americans have the highest death rate and the shortest survival of any racial or ethnic group in the country. And for a population that only comprises less than a quarter of the US, that's an alarming statistic. In terms of leading sites for new cancer cases among African Americans, it's still a third for men and women. And so we see here that the estimated deaths are also about 7,000, estimated new cases are about 17,000 for that year. The rationale for earlier screening are higher incidence, higher mortality, decreased survival, more proximal site distribution of adenomas, the possibility of a biological difference in the colorectal cancer itself, and barriers to screening. Now, this morning we're only going to focus on screening. As you can imagine, it could be various lectures about the other things like proximal site distribution or the biological difference of the cancer itself. That is to be considered after the patient has undergone screening. So what is going to be the rationale for getting them into the screening programs? And so we see here the trends in colorectal cancer incidence. Between 1975 and 1985, actually white men had a higher incidence of colorectal cancer. And through about 1985, you see this precipitous drop here. African American men had a lower incidence, and then this dichotomy here continued to increase. And African American men wouldn't see a decrease in their incidence until about the early 2000s. For women here, we see that white women had pretty much, and black women had pretty much equal incidence if you want to look at this part of the graph. And then after 1985, there was a precipitous drop for incidence in white women, and African American women pretty much stayed the same until, again, about the early 2000s when it started to drop. Now, this is a great graph by Carruthers looking at the earlier age for colorectal cancer in African Americans. And what was found here was that if you have the proportion of colorectal cancers diagnosed under a target age, and that target age for whites is 50 years, the proportion of colorectal cancers diagnosed under there was 5.5%. Now, let's keep the same target age for African Americans at 50. The proportion of colorectal cancers diagnosed under that age would be twice as much, 10.6. Lowering the target age for African Americans to 45 will even the play field, so to speak, in terms of the proportion of colorectal cancers diagnosed under that age. So again, this feeds into the earlier rationale, or the rationale for earlier screening. The racial trend of colorectal cancer mortality, similar pattern to incidence, in which white men had a higher mortality up until 1985, and then it started to downtrend. And then African American men continued to increase till about the early 2000s, and same pretty much the same for women here, where white women and black women had pretty much the same mortality, and white women started to go down, and African American women pretty much stayed the same until the early 2000s. The 5-year survival data that we have, remembering the cartoon that was showed for stages of disease and survival, African Americans, depicted here in the purple, have for all stages of disease worse survival, whether it's localized, regional, or distant disease. So let's go into the patient barriers for the latter half. Now, this is a wonderful table that was published by Ward, looking at perceptions of colorectal cancer screening among African Americans. And what he found that these perceptions were leading to their barriers to completing screening. Let's first go into lack of knowledge. African Americans have an underestimation of their risk of colorectal cancer. Their lack of understanding of screening colorectal cancer can be prevented. Their lack of knowledge that colorectal cancer is treatable, and the type of screening tests available they're unaware of. Now, what could be a facilitator for completing screening? And this is what's here on the right-hand side. So hope of a positive screening outcome. Now, what does that mean? That means that if you give the African American the knowledge that they have over or increased risk of colorectal cancer, and that they actually undergo colorectal cancer screening, their hope of finding a precancerous lesion to have it removed to never become cancerous has been shown to be a facilitator for screening. Just to emphasize the knowledge barriers here, a study done by Green in 2004, querying 100 African American men and women, asked them about their knowledge, perceptive, and access barriers to colorectal cancer screening. And what was found was that 43% of those in the study thought that there was no known cause for colorectal cancer. 40% thought that there was absolutely no preventing it, and 38% thought it was usually fatal. Perceptive barriers here was mostly fear. 47% feared pain, 33% feared not knowing what the test itself was going to be like. Access barriers, 54% didn't know how to schedule or go about scheduling a test here. So it's not just one particular barrier within this community, it's a multifaceted barriers that have to be addressed at different points in time when you're recommending screening for your patients. Now, the perception of risk, which I found particularly interesting. So African Americans, again, have often the misperception that their risk of getting colorectal cancer is low. 36% of African Americans at a community health center rated their risk of getting colorectal cancer as below average. Another study showed that among those that did perceive the risk of getting colorectal cancer were unaware that they can do anything about it. So bottom line for us is that we need to inform our African American patients that they are at an increased risk for colorectal cancer by virtue of their non-modifiable risk factor of race and all the barriers that go along with that. The low perceived need for screening. Now, how do we convince someone to get screened if they don't think they need to be screened? The belief that screening is only needed for symptoms, if symptoms are present, has been well published in the literature. One study stated that African Americans thought that they only needed to be screened if they saw blood in the stool. Now, we know that at that point in time, you're seeing blood in the stool. It's no longer considered a screening test. It's now considered a diagnostic evaluation for their symptoms. Now, how do you facilitate completing screening in that instance? Accuracy and thorough and accurate test results. Now, what does that mean? That basically means that if a patient perceives they have no symptoms, telling them that having the screening will allow us to make sure accurately and thoroughly determine that they don't have any precancerous lesions in order for them to be sure that they don't develop cancer in the future. And so going from convincing a patient that they don't need screening because they have no symptoms to letting them know that there still can be things found in your colon that can have you have symptoms later in the future has been facilitators for completing screening. Now, what about fear? So we saw here in the previous study that there was a big fear of pain, a big fear of not knowing what the test detected. Here we see that embarrassment and a culture of silence regarding cancer has been rampant within the community. Now, facilitators for completing screening has been physician recommendation. And why is that? Because partnering with your doctor to have your doctor know your fears, your embarrassments, and to answer questions has been a remarkable facilitator for this community. Fatalism. So the idea that there's no option for treatment or cure of colorectal cancer has been seen in the literature. Once cancer has developed, there are no options for treatment, one study found. 25% thought that colorectal cancer was not curable. 58% believe that people have no control over detecting the cancer early, which we know is false. And another primary fatalistic belief was that surgery can spread the cancer. Why get the surgery that can cure me if it's just going to spread it anyway? Again, a fatalistic barrier. Now, what can we do? A lot of these fatalistic beliefs are rooted in religious, right? Religious bearing that if God let it happen to me, then just let it be. However, the facilitators for completing that screening is to align their fatalistic beliefs to say that God's holy temple is your body, and caring for your body is something that God would want you to do. If that patient has that fatalistic belief, that's been shown to be helpful in some of the studies. Now, mistrust. Mistrust for being used as guinea pigs for unnecessary or unproven procedures. Now, we know that this is deeply rooted in the history of mistreatment and racially motivated discrimination that African Americans had to endure for years and quite frankly are still enduring today. How do we come to a patient who's had a family member who was part of Tuskegee? The last Tuskegee patient actually died in 2004. That was about 15 years ago. And so what is a facilitator for completing screening in patients who just have a genuine mistrust of the medical system? Empower them. Have them become an active healthcare seeker within their own selves and within their families' and communities' lives. By partnering with your patient and by also being their advocate, you would gain that trust, and it's been shown to be a good facilitator for completing screening. Now, we know financial and access to care have been barriers for a very long time. The cost of screening, the lack of insurance, quite frankly, the time available that they have to screen if they want to undergo a colonoscopy, these have all been barriers. And the facilitator that has been pretty good is the peace of mind and decreased worrying. Now, what does that mean? Meaning that patients are willing to take the time off if that would decrease their anxiety of having something happen in the future. And so letting them know that you're going to walk them through the process of getting screened, and at the end of the day, they don't have to worry about it for hopefully maybe another 10 years if no polyps are found, has been encouraging to them. And so I'm sure at this exact point in time that President Obama in 2010 was sitting around and he was thinking about and contemplating what kind of colorectal cancer screening he was going to get done that year. And President Obama was extremely smart and decided to keep his presidential powers and got a CT colonography. Now, that was back in 2010, and I'm not sure what he's done for screening since then, but I want to go on the record to say that he is more than welcome to come here for us to screen him for colorectal cancer. No, but will giving patients a choice impact adherence? And so Inadomi found that no, it actually won't impact adherence, giving your patients a choice and having them choose between one or another. So what's shown here is that there are patients who were assigned to an FOBT arm, a patient was assigned to a colonoscopy, and patients who were actually given a choice. And actually, if you just assign the patient a colonoscopy arm, 38% actually completed the study, versus about 69% who actually completed if it was given a choice. And that was found to be no different from patients who were just assigned FOBT. So ultimately, giving your patients choices can actually be helpful in them becoming more adherent to one test or another. Now, racial differences in adherence, there has been shown that there may be some preferences among African Americans as to what type of screening tests they would like to do. And seeing here for African Americans in the choice arm, 34% versus 20% were completing FOBT, versus in whites, 52% chose colonoscopy versus 18% choosing FOBT. This was also seen in Shokar's study, in which actually 67 versus 54% whites completed any test more than African Americans. However, when looking at FOBT, African Americans had a higher percentage of completion versus whites, and whites had a higher completion of colonoscopy versus African Americans here. And so again, giving a choice is great. Having to elucidate the patient's preference is even better when you're giving them the choice so they can be more adherent. Now, within the same study, being current with colorectal cancer screening was strongly associated with having a regular doctor, annual exams, and a doctor recommendation. Now, minorities in the study reported lower rate of doctor recommendation for screening. So it brings to mind what could be the physician barriers to colorectal screening recommendation. Now, provider recommendation emerged as a key theme in some studies, showing that it leads to increased compliance. In one study, it showed that African Americans who received a recommendation from their physician were nearly 6 times more likely to be adherent. In this particular study by Coughlin, he used the U.S. Census Bureau survey that went out to 36,000 households, and it was querying them about if they received colorectal cancer screening and if they actually received a recommendation. Now, African Americans were just as likely as white men and women to get physician recommendation for FOBT, but they were less likely to get a recommendation for endoscopy versus white men and women. And the factors that were associated with non-recommendation include a lower education, having more than 3 children, a shorter duration in the US, income below poverty level, unemployment, and having no health care. Other disparities in physician recommendations have been published in the literature as well. In terms of one study here by Grenier, given a choice between FOBT, sigmoidoscopy, or colonoscopy, 39% were not sure of what they would choose, but they stated they would follow whatever their doctor recommended. 33% of them actually didn't even remember receiving a recommendation for FOBT, sigmoidoscopy, or colonoscopy. In another study that investigated physician recommendation over the past year for patients who were seen, African Americans were 1/3 less likely than whites to receive a physician's recommendation for screening. In this particular study, insurance was not a significant predictor of a physician's recommendation. However, if less income was reported, it was less likely to be recommended. And if more education and more physician visits, they were actually more likely to be recommended. Now, this was a study that was abstract that was actually published here in Mount Sinai, looking at the knowledge scores based on the American Cancer Society guidelines for average risk patients. And the knowledge scores for these guidelines was low among all medical students, residents, and attendings in the study. The knowledge scores for high-risk patients were even lower, fewer than half of the respondents offering correct answers. The knowledge scores for general colorectal cancer screening facts, basically these were the facts that the ACS guidelines were based upon, were also low for medical students, residents, and attendings. And so knowledge barriers existed among healthcare professionals working in a low-income, predominantly minority community. Now we can ask ourselves, this is one place at one time in a major city. What about the nation? So this is what was queried here in our study, looking at a national survey of physicians. And in this study, we wanted to see what the physician knowledge and adherence to colorectal screening were guidelines for high-risk patients. After all, these are the patients that need it the most, right? The secondary outcome were physician barriers to colorectal cancer screening. We used the AMA database, we used a 19-item survey, we sent randomly to 25,000 internists, family medicine, and we also include our gastroenterologists. They're the specialists, right? We're the specialists. We should know what's going on, right? And we stratified this sampling strategy by seeing if you're coming from a low incidence colorectal cancer state, a moderate incidence colorectal cancer state, or a high incidence colorectal cancer state to see if that had any impact on your knowledge, if you're seeing it more or less. And so some sample questions included, at what age would you recommend starting to screen your Asian American patients with no family history? A patient who has a brother and a father diagnosed in their 70s, what age would you recommend screening and how often? And what age would you recommend your African American patients with no family history of cancer? Now, I'm not going to take a poll, I'm just giving a sample of what was sent. And the baseline demographic characteristics included basically 512 respondents, most of whom were white men who practice internal medicine in suburban areas and were practicing for 20 years. There were representatives from 28 states, most coming from California, about 18%, and most coming from low colorectal cancer states at 40% here, versus 33% for moderate and high colorectal cancer states represented 25%. And what was found was that there was no statistically significant difference in knowledge scores based on whether they came from low, moderate, or high colorectal cancer states. There was no significant difference seen in practice location, whether it was suburban, urban, or rural areas, and there was no difference in knowledge between men and women. But what was seen was a difference in knowledge scores by specialty. And so family physicians scored 31%, internists 34%, and gastroenterologists scored 50%. Now we can look at our gatekeepers and say these are the people who are having our patients come to us. But even as gastroenterologists, our knowledge scores were 50%. There's lots of room to go across the board. 92% actually correctly identified age 50 as the point of initiation for an average risk Asian patient, but only 28% identified 45 as the ACG recommended initiation point for African Americans. And mind you, these survey questions were based on USPSTF data and also guidelines and also ACG guidelines, so both. Black physicians were the subgroup more likely to correctly identify the screening age for African Americans compared to their peers, 66% versus 27%. Other patterns and cited barriers, we see here that those who are practicing more than 5 years cited lack of reimbursement as a barrier. And those who are practicing less than 5 years, so straight out of residency or fellowship, basically cited lack of evidence to support recommending earlier screening as a cited barrier more than the other group. Out of all the physicians, 43% reported barriers. And out of those, 72% had 2 or more. Patient refusal was the first. Lack of insurance, 64%. Anxiety for patients, 58%. But unaware of the current guidelines accounted for close to a quarter of the barriers that were cited in this study. And so if we as physicians have our own barriers in terms of knowledge, in terms of recommendation, how about all the barriers and time constraints? And again, looking at the lack of evidence. And so we ourselves are dealing with barriers too, not just our patients. And so what are the interventions to increase colorectal cancer screening that have been shown? And so just like patient barriers that have a multifaceted, barriers to screening, we have to approach it in a multifaceted way as well. And so we can see here, we can approach it via communities or individuals or us as healthcare professionals. And the literature shows that when you're approaching it in a community setting, by community, there have been shown to be higher intentions to screen, but 1.5 times more of a patient's intent to screen. They have more positive beliefs about colorectal cancer screening, but the actual compliance with screening was not significantly higher in some of the studies. Individually, if you're attacking that from that standpoint, the completion rate in one study for FOBT or colonoscopy was 4 times higher. And these were patients who were receiving educational materials, media, brochures, calendars to put, when their screening was. So actually having that was great, but the absolute rate of screening was only 27%. What about our healthcare professionals? There were different studies looking at giving monthly lectures, weekly morning reports, increased flexible sigmoidoscopies by 42%, some studies. The absolute number of patients screened there actually was only 71. The increase in resident physician endoscopic referrals, so having them at the trainee level, okay, after didactic sessions and endoscopy observations was pretty great with, in the study by Friedman and Borum at GW, where we had endoscopy, have residents come down to didactic sessions and also go to endoscopy to observe a colonoscopy and observe a flexible sigmoidoscopy and see the importance of it. That actually did increase it. But as you can see, not one strategy is going to be sufficient. We have to hit it from multiple levels within the system. Patient navigation does a wonderful job in doing so. In a study by Jandorf showing that those who are patient navigated, again, hitting the barriers for patients in terms of access to screening and knowledge, showed that after 3 months, patient navigated group had actual an endoscopy appointment. And those that completed endoscopy at 6 months was 24% versus 5% in the unnavigated group. So again, patient navigation has the ability to hit multiple patient barriers at one time. So our approaches to increase screening should be multiple strategies that should be employed to deliver the intervention. It should tailor the specific intervention to address patient-identified barriers. We should personalize the education materials, and it's been really good to show that culturally sensitive approach has worked in the past. Recruit in familiar community settings has been wonderful in terms of a trial done by Ravenel at NYU called the Mr. B trial that went into barbershops, navigating patients, and also increasing those that underwent colonoscopy appointments versus those who weren't navigated. And educating us, the healthcare providers, is also the approach that needs to be taken. But what is unknown, and I leave you here with today, is what is the barrier, the most crucial to be addressed to ensure the success of an intervention? Is it X? Is it X, Y, and Z? That's unknown. And more research needs to be done to say, if I have this intervention, I'm going to be ensured to be successful. We don't know the answer to that right now. However, we do have a shining star. And we do have, a silver lining in this cloud given to us by the New York City-wide Colorectal Cancer Coalition, or C5, which is a major public effort to increase colorectal cancer screening in New York City and addressing health disparities. Now, this, again, wasn't a one-pronged approach, okay? They had patient navigation, direct endoscopy referral, public health outreach to underserved communities, as well as outreach to the physicians in their offices to increase colonoscopy screening. And if you see here, the national average was 52% back in 2003, and at that point it was 42% here for New York City. By 2007, the disparities for white, blacks, and Hispanics were eliminated. And by 2013, our Asian population came into the cohort to eliminate disparities here, screening at a little less than 70% at 68%. So it's doable. It's doable with a multi-strategic approach. And so in summary, colorectal cancer disparities in incidence, mortality, and survival persist in the African American community. The lack of knowledge, fear, mistrust, and access to care are major patient barriers. The lack of knowledge of screening guidelines and lack of recommendation for screening for African Americans have emerged as major physician barriers. But overcoming the disparity gap, as we've just seen with C5, is not beyond our grasp, but we all must do our part in reaching toward the common goal of breaking down the barriers. And I want to give a special acknowledgement to Dr. Steve Itzkowitz, Lena Jandolf, and Dr. Fritz Francois, who have been instrumental mentors to me in the past as well as my current endeavors within this field. Thank you for your attention.
So one of the most effective ways to get patients to screen black patients in a different disease, one of my diseases, was to go to the churches and mosques, get the religious leader to say something from the pulpit in favor of screening. And has that been tried with the colorectal area?
Absolutely. And so looking at some of the data, one of the individual outreach that was done, that one study looked at looking at the church members, and that's when they gave them educational videos, calendars, media, and as well as giving the church leaders a time to have the congregants, so to speak, listen to colorectal cancer, facts and figures. And that was the study that had the 4 times more FOBT and colonoscopies that increased. And so I definitely think that community outreach, so we talk about in-reach, right, when we have patients come to us, but outreach has been instrumental in getting that done. And even so to speak here with regards to the East Harlem Partnership of Cancer Awareness, or the Black Witnesses of Harlem, they're reaching out to the community in ways to just inform them about colorectal cancer screening or breast cancer screenings or cervical screening. So absolutely it's been tried and it's been successful. But again, it's not just one thing. We have to reach them at multiple levels within the process.
Thanks. Once patients engage in the colorectal cancer screening process, are you over that hurdle of engagement, or do you still see barriers in terms of follow-up and treatment and other aspects of cancer care?
I was just talking to Steve about that last month, right? So we don't have any data that's looking at the surveillance portion. He says that we can assume that it's great because they've had it done before and the barriers are over, but we actually don't really know whether or not they continue to be engaged in the screening process. Because after that first FOBT is sent, 3 cards are sent, do they come back for the second and the third and the fourth? That's still ongoing in terms of surveillance, in terms of other screening approaches. So I'm not sure, but that was a question that Steve and I were discussing during our research meeting.
What is a significant difference between sigmoidoscopy and colonoscopy, and statistically, just in terms of getting on that?
In terms of screening African Americans?
Yeah, and yeah.
I'm not sure about the statistics, but we can say in terms of proximal adenoma risk, right? So there have been 3 studies that have been shown that the odds ratio for having a proximal adenoma was higher in African Americans than for whites. And so about 1.3 to 1.5% higher odds ratio for having a proximal adenoma. If you can imagine giving your patient just a flexible sigmoidoscopy, you are missing the right side of the colon. So I don't have exact numbers, so to speak, but the impetus to screen the entire colon is there just by virtue of the possibility of missing a proximal adenoma that won't be removed during the procedure.
Is there a difference in incidence in obese patients of colorectal cancer? Because
Absolutely.
In breast cancer, there's definitely a poorer prognosis, a poorer outcome, and a higher incidence.
Absolutely. So obesity is a major risk factor for colorectal cancer. We're seeing a lot more studies being done for early onset colorectal cancer. The Nurses Health study that had some data come out over the summer looking at those nurses who were more obese or had higher BMIs than the other nurses had colorectal cancer diagnosed more often. We're looking at that in terms of for your African American patients who are diagnosed with childhood obesity, does that increase their risk for them getting early onset colorectal cancer? Because again, we don't know what causes it, but absolutely obesity is a risk factor.
Yeah, Pascale, that was great. Thank you. And thanks for the shout out about C5. Increased colon cancer screening rates in New York tremendously, but I think the most impressive thing is the disparity
Absolutely.
shrinking down. And a nice shout out about navigation also, which I think is a really big deal.
What other points would you like to highlight?
I love the whole thing. Here's my question too. So the American Cancer College of Gastroenterology suggested 45 for African Americans almost 10 years ago.
Mm-hmm.
American Cancer Society did it for everybody. But the insurance companies haven't caught on to this. So what practical tips do you have for people for getting the African American population screened at age 45?
I think the first, it's again a multi-approach. They first need to know that they should get screened. And number 2 is, in working in the gastroenterology clinic myself, I haven't had any problems with getting my patients at 45 screened, for African American patients screened at 45. I haven't had pushback from the insurance companies. But I think practically speaking, there's more to come, right? So the USPSTF is now looking over their guidelines earlier than usual to see if they should come on board with 45. I think once the insurance companies are seeing that other societies are getting on board with this and looking at the data closely and seeing that that 40 to 49 age range is what's driving this early onset colon cancer, rectal cancers mostly, I think that would give them the edge. But in terms of the African Americans, they first need to know. They first need to be told blankly, you are at increased risk. And why am I at increased risk? It's because of your race. That's all we know.
But that's by the time they got to you.
That's right. That's right. So that's why the community outreach, so in-reach is one thing, outreach is another thing, and just being aware.
So how much of this should be algorithm-based and driven in a non-physician directed way? In other words, it should be something we should be building, hardwiring into our system
Absolutely.
to avoid any of the biases that are inherent in our system.
Absolutely.
Is that a good
Thank
question?
you, yeah, that's perfect. That's great.
Dr. Muller.
That was a great presentation. Thank you. It was really thorough. In the very beginning, you had a slide that listed quickly the modifiable and non-modifiable risk
Yeah.
factors. And the non-modifiable, you included race.
Correct.
And I'm wondering what your thoughts are about how much of that is non-modifiable because of literally differences in biology. You can't change the color of someone's skin. And how much of it is non-modifiable? How much of it is modifiable because of the different impact of social determinants based on someone's race, the impact of racism based on someone's race? And I don't know if race belongs in non-modifiable or belongs in very difficult, but we should aspire to modify.
That is a fantastic question. And I think it's been tried to, and that kind of goes into the biological differences in the tumor itself, in which some studies showed that, for example, microsatellite instability, which has a favorable prognosis, has been found to be less so in African American cancers. 14 to 7% in one study, versus other biological differences such as EMAS, which is basically microsatellite, another microsatellite alteration site, which has been found most often in rectal cancers. Again, more often it promotes a worse prognosis and increase in metastasis for this one. And so I don't think that there is one particular reason why race is a non-modifiable risk factor. I think that there are many reasons why, including socioeconomic, not taking that for granted, but also there have been studies looking at the tumor biology itself, and until we know more about it, we can't really tease out, you're just a high risk because you're black, and you're high risk because you also have, you don't have access to care. All of that has plagued the community. There's no way to really tease that out in the person who's sitting in front of you. But what can be done is teasing out their barriers. And by virtue of looking at their barriers, it's just on top of the fact that they're black. So everything is multi-layered. It's not just one thing. But there have been shown to be biological differences. And by virtue of them having barriers on top of those potential differences, makes that, they can't change that. And we won't know until we screen them and find out, hopefully not finding a cancer.
No, somebody knows.
What are the chances that in the next 5 or 10 years, those biological differences will be borne out to be a result of epigenetic differences that are determined by social stressors on people, things like poverty and violence and racism?
I want to be a part of that study. I mean, for sure. I mean, in 5 years, I think there'll be more information. Hopefully, there'll be more information, again, garnered from the ongoing studies looking at early onset. Because at this point, we're talking about patients who are in their 40s. We're looking at patients who are getting diagnosed in their 20s and 30s. And so hopefully there'll be more information garnered about, these patients at 20 haven't had as much, I guess, happen to them than those that are 45 in terms of their socioeconomic and status. But hopefully there'll be more information. I'm hopeful.
Thank you very much for super.
Thank you.